Welcome back. Today we are talking about acute exacerbation of COPD, what's happening physiologically, how to recognize an early deterioration, and how to manage it safely in the field. COPD is not just wheezing. It's a chronic airflow limitation, usually from a mix of chronic bronchitis and emphysema. You will sometimes hear the old shortcuts like blue blotter and pink puffer. They can help picture the extremes, but most patients sit somewhere in between. What matters in the field is this. During an exacerbation, the patient can deteriorate because air can't get out, air trapping builds. The work of breathing skyrockets, CO2 rises, and fatigue can set in quickly. People still use the old labels, blue blotter and pink puffer, not because they are perfect, but because they describe two ends of the COPD spectrum. On the chronic bronchitis side, there are more airway inflammation and more mucus, so gas exchange tends to suffer earlier. And over time, you can see signs of right heart strain. On the emphysema side, the core problem is a loss of elastic recoil. The lungs don't spring back the way they should. So exhaling becomes work. Air gets trapped. And patients compensate with prolonged expiration and pursed lip breathing just to keep the small airways open. But in the real world, most patients are mixed. So I don't chase the label. I treat what I see. Obstruction, air trapping, and signs of fatigue. Here's the key physiology that explains why these patients crash differently. In a healthy person, exhalation is mostly passive. In COPD, exhalation becomes the work. When the airways are narrowed and inflamed, and mucus is present, air struggles to leave the lungs. So each breath can stack on the next. That's dynamic hyperinflation. And once hyperinflation builds, the diaphragm flattens, the work of breathing skyrockets, and the patient starts burning through their reserves. At the same time, gas exchange becomes less efficient. Ventilation perfusion mismatch increases, oxygenation can drop, and CO2 clearance can fail. That's why a COPD patient can become hypercapnic and acidotic. And once fatigue sets in, deterioration can be fast. So I'm not just listening for a wheeze. I'm watching for the moment ventilation starts to fail. So in the first minute, I'm trying to answer one question. Is this patient ventilating or heading toward failure? I look at the speech, the mental status, and the pattern of breathing, especially the length of expiration. I pay attention to chest movement, because a quieter chest is not always an improvement. Sometimes it means less air is moving. And if I have capnography, I use it, because trending CO2 tells me a lot about ventilation in real time. Once I have that picture, the next step is oxygen. But in COPD, oxygen has to be deliberate. My target is to keep the saturation around 94%, not to chase 100. Too little oxygen is dangerous, but flooding oxygen without watching ventilation can hide a rising CO2 problem. So I titrate. I watch mental status closely, and if I have capnography, I trend it. And if the patient is still working hard or starting to tire, I don't just turn up the flow. I start thinking about ventilatory support. If the patient is in significant distress, but still awake, cooperative, and protecting the airway, CPAP is worth considering, used carefully. It can reduce the work of breathing by offsetting intrinsic PEEP and improving ventilation while medications start to work. I start low, around 5 centimeters of water, and I watch closely, because CPAP only helps if the patient can tolerate the mask and if their trajectory is improving. But CPAP isn't a substitute for recognizing failure. If the patient is tiring, becoming confused, losing chest movement, or can't tolerate the mask, that's not a CPAP patient anymore. That's a patient you need to ventilate, and you need to be thinking early about airway management and safe transport. Now we treat the obstruction directly. I start bronchodilatators early. Ventolin, salbutamol, 2.5 milligrams by nebulizer, and Atrovent, ipratropium bromide, 0.5 milligrams by nebulizer. The goal isn't just to hear less wheeze. It's to improve air movement, reduce trapping, and lower the work of breathing. Then I reassess speech, effort, chest movement, and trend. At the same time, I give steroids early, because they change the next hour, even if they don't change the next minute. Solormedrol, or methylprednisolone, 125 milligrams IV as a single dose. And while all of this is happening, I'm also looking for what triggered the exacerbation. Because COPD flare is sometimes infection, sometimes smoke exposure, and sometimes a different emergency entirely. That's why I get a 12-lead ECG early. In many of these patients, the respiratory distress is tightly linked to a cardiac stress. Arrhythmias, ischemia, or heart failure can be the trigger or the consequence. And if something doesn't fit, sudden pleuritic pain, unilateral findings, unexpected hypotension, I keep differentials on the table, like pneumothorax or pulmonary edema. Reassessment is where you win. If the patient is improving, breathing slows, speech returns, air entry improves, keep treating and transport. If they're worsening, quieter chest, rise in fatigue, and decline in mental status, don't get stuck on scene. Escalate early, support ventilation, and move. In COPD, the patient who gets quieter isn't always getting better. Sometimes they're running out of airflow. During transport, I keep the patient upright, keep the environment calm, and continue treatment without interruption. I reassess repeatedly, work of breathing, speech, mental status, and oxygenation, because COPD patients can deteriorate during movement. If the patient's trajectory is worsening, I shift focus immediately to ventilatory support and airway readiness, and I prioritize rapid transport over doing more on scene. Managing an acute COPD exacerbation is about recognizing airflow failure early, treating obstruction quickly, and supporting ventilation before fatigue takes over. Titrate oxygen with intent. Use bronchodilatators and steroids early. Consider CPAP when appropriate, and keep reassessing the trajectory. Thanks for listening.